ఇది టైం లిమిట్ ఏమైనా ఉందండి మనకి?
అట్లా ఏం లేదు.
ఓకే ఓకే.
ఇంకా మీకు హోస్ట్ చేసిన చూడండి. ఓకే.
ఏం చేశారన్నారు? నన్ను హోస్ట్ చేశారా?
అవును.
ఓకే ఓకే, రైట్ అండి. యా ఓకే. నేను హోస్ట్ అనేసి ఇక్కడ వస్తుందా? వస్తుందేమో కదా, చూస్తాను. అలాగేనండి.
మీరే హోస్ట్, నేను కో హోస్ట్.
ఈ సుధాగ్రేస్ హోస్ట్ కో హోస్ట్ అవసరం లేదు. డేవిడ్ సార్.
సార్ డ్రైవింగ్.
డ్రైవింగ్ కనిపిస్తుంది. డ్రైవింగ్ కనిపిస్తుంది మీది.
అనిపిస్తుందా? ఆపేసాను. ఓకే, అయితే వస్తుంది కదా రాజేష్?
వస్తుంది వస్తుంది వస్తుంది.
2 నిమిషాలు ఆపి నేను స్టార్ట్ చేస్తానులే, తర్వాత నువ్వు కంటిన్యూ చేయి. నువ్వు ఇంట్రడ్యూస్ చేయొచ్చు.
అలాగే సార్,
నేను స్టార్ట్ చేస్తాను.
అలాగే
అలాగే
సార్.
ఒక 2 minutes ఆగుదామా?
ఒక 2 minutes ఆగుదాం సార్. ఇంకెవరు ఎక్కువ 9 members లాగానే అయ్యారు. 2 minutes ఆగుదాం.
మెల్లి జాయిన్ అవుతారు.
ఓకే. We'll start at 7:45. ఓకేనా?
ఓకే సార్.
స్టార్ట్ చేద్దామా
సార్? ఇప్పుడు ఎంత అయింది? 7:34 అయింది కదా. మనం ఒక 7:45 స్టార్ట్ చేద్దామా? ఇది టూ లేట్.
7:40
7:40 స్టార్ట్ చేద్దాం సార్.
అలాగే. ఓకే అలాగే.
ఓకే సార్. Mohan sir, good evening. We're waiting till 7:40 and we'll start.
గుడ్ ఈవినింగ్ సార్.
Sir, good evening, sir.
Sir, good evening.
Hi, Rajesh, good evening. Ma Sharada, thank you very much. మరి పర్సనల్ గా ఫిజికల్ గా కలవం కదా మళ్ళీ ఇంకా రేపు నైట్ డ్యూటీకి వచ్చేప్పటికి నేను వెళ్ళిపోతాను కదా.
Oh sir. మోహన్ సార్
చెప్పండి సార్.
అదే ఇక్కడ ఉన్నారా?
అంటే అలా కాదు, అంటే అనవసరంగా స్పీకర్ మిగిలిన అందరికి డిస్టర్బెన్స్ అని వీడియో ఆపేసాను అంతే.
కాదు మీ వాయిస్ ఇక్కడ కూడా వినిపిస్తుందని చెప్తున్నా.
ఓహో సారీ, ఇక్కడ మామూలుగా వినలేదు, ఏదో ఇక్కడ మాట్లాడుతుండే చూడలేదు, స్పీకర్ ఆఫ్ చేయలేదు.
అలాగే. Okay, 7:39 countdown starts now. David sir? David sir?
Yeah, Achyut.
9
Yeah,
7:40
shall we start?
స్టార్ట్ చేసేద్దాం సార్.
Good evening, all. Today we are conducting a webinar on sepsis on behalf of World Sepsis Day. Actually, we would like to conduct on 13th yesterday on World Sepsis Day. Due to so many webinars are there, so we would like to postpone one day for making a more attendance. On this World Sepsis Day, we asked the speaker to talk on sepsis and the sepsis related issues because sepsis has become the world threat nowadays and one of the major cause of death globally. And this aspect, everybody and all the ICUs are suffering with multi-drug resistant bacterial and viral and fungal infections. The antibacterial and antifungal and antiviral drugs also are becoming exhausted and the pipeline of antibiotics become dried. The availability of the antibiotics and the bugs becoming resistant day by day due to indiscriminate and the excessive use of antibiotics. And we are receiving the patients to our tertiary centers in a multi-drug resistant bacterial infection in a critical condition. So in that scenario, patients who are not responding to the usual antibiotics, even higher antibiotics, and that time we would like to put the patient on extracorporeal therapy once patient is not responding well to save the patient life. Now I request Dr. Achyut to start the program and continue that. Achyut.
Yeah, okay. Thank you very much, Dr. John David sir, for the introduction to the today's evening. So we all know that yesterday was World Sepsis Day, and that was celebrated or whatever verb to use, but it is to basically to increase the awareness in the public and also in the doctors and the healthcare professionals regarding sepsis. And extracorporeal therapies are one of the important modalities of treating sepsis, and it is a recent advance, involves lots of recent advances. So this is something that could help us to get our patients better along with the antibiotics, which is the major treatment, major weapon in treating sepsis. So we have Dr. Rajesh Kasimahanti, who is my colleague in Apollo Hospital's Health City, Visakhapatnam, in the Department of Critical Care Medicine. And he has done MBBS from Andhra Medical College and then MD from PGI Chandigarh and did fellowship in critical care from SGPGI. And he has done fellowships in critical care from Singapore and Canada. And he is with us for the past 1 year. And he is academically oriented, and his basic areas of interest is sepsis and antimicrobial resistance. And I'm sure he would do justice to this topic, and we'll start it very soon. And at the end of this program, we would have discussion with contribution from the seniors in the group and also the healthcare professionals and everyone who is participating in this webinar. And I thank the ISCCM National Body Executive member, Dr. Mohan Maharaj, for logging on time and guiding us for conducting this program through. He suggested that we conduct this program in a bigger scale physically also, but we haven't organized this program in the time frames required for getting sponsorship. So because of that gap, we are going for webinar instead of physical lecture. Apologies for that, but I'm sure all the participants will be happy at the end of this session, and we are saving them from traveling the distances. So that is one justification that we are pushing across. So over to, I request Dr. Rajesh to continue or start his lecture, and all others to mute their microphones. And at the end, we'll open everyone for speaking out, right? Over to Dr. Rajesh. Rajesh, please proceed.
Thank you, Achyut sir, and thank you, ISCCM Visakhapatnam chapter, for giving me this opportunity. I personally thank Achyut sir and Dr. David sir and Mohan sir for attending this. So the topic for discussion is extracorporeal therapies in sepsis. Like all of us know, and we have repeated this again. So this is the current trending hashtag on Twitter, hashtag sepsis, on the occasion of 10 years of World Sepsis Day. So September 13th is considered as the World Sepsis Day. So on a nutshell, the current theme for this Sepsis Day is to make sepsis as a national and global health priority. So the Twitter handle says 1% dies of sepsis every 2.8 seconds. So since the time we waited for 5 minutes to start this webinar, there's been almost 100 people would have died because of sepsis. And it is the leading cause of death in hospitals, and almost all, it makes poor people even poorer, and it is the reason for people going below the poverty line, especially when you are admitted with sepsis with multi-organ dysfunction. So this is the title topic. So I'm Dr. Rajesh. I'm working as an intensivist at Apollo Hospitals. So the current topic I'll be discussing about extracorporeal therapies, mostly related to non-COVID sepsis, but here and there I might touch about COVID-19 sepsis. And for a big inverted quotations, this is not an industry session. This is, I would like to thank ISCCM Vizag for giving this opportunity. And my experience with these extracorporeal filters, I have used, I won't say I'm an expert, but I've used a good number of different types of these extracorporeal therapies in sepsis. Okay, so this will be the outline of topic. I'll start with sepsis current definition, and what is the immunopathogenesis, and what are all the novel strategies for treating sepsis, and the rationale and principles of using extracorporeal therapies. And I'll describe about different types of filters, and I'll conclude with my own personal conclusions about where and when these filters should be used. So current sepsis 3 definition, we have only sepsis and septic shock. It completely says no to terminology, something like severe sepsis or severe septic shock. This is to all our colleagues who are trying to still write severe sepsis and severe septic shock. So sepsis is defined as a life-threatening organ dysfunction secondary to a life-threatening infection, and septic shock is sepsis plus hypotension. So coming to the extracorporeal therapies in ICU, so there are like so many types of extracorporeal therapies. So as the name suggests, it is extracorporeal, which is done outside the patient body. And when you come to the definition of what is an extracorporeal therapy, so it is an heterogeneous group of treatments which promotes removal of either endogenous or exogenous poisons or toxins, or at the same time, they will support or temporarily replace an vital organ, or they can do combination of these both. So these are all the common extracorporeal therapies we use. The most common will be renal replacement therapy. I'm sure like 10 to 20% of our ICU patients will be on some sort of renal replacement therapy, and some sort of hemoperfusion therapies, especially for toxins and drug toxicities, and hemofiltration therapies for some specific indications like total plasma exchange, and ECMO is coming in a great way into ICU. So that's also part of an extracorporeal therapy. And among the indications, apart from dialysis and toxin removal and total plasma exchange for specific diseases, sepsis is an area where extracorporeal therapies has been growing, and I would say it has reached a plateau, and there has to be a lot of interest and research using extracorporeal therapies, especially in sepsis. So sepsis, when you think about sepsis, it's my professor used to say the diagnosis of sepsis is a dustbin diagnosis. But as I've started with, it is the leading cause of hospital mortality. So there's been always a lot of research going on about novel strategies for treatment and novel strategies for improving the mortality. Whether it starts from the so-called vitamin C therapy to the magic cocktail of hydrocort, vitamin C plus thiamine, or immunoglobulins, or whatever, there's been a lot of research about looking for novel strategies for sepsis, but we couldn't reach any major mortality benefit in sepsis treatment because there's been a lot of heterogeneity in patients who are getting admitted with sepsis. So if you see all the like near 100 randomized control trials done on sepsis, there are hardly few trials which have shown mortality benefit, even comes to critical care. So even when you look at the mortality in case of control group, the mortality can be as low as 20% to reaching as high as 80%. So this specifies heterogeneity of sepsis patients. So that's why there is no specific or novel strategies yet found apart from the currently available so-called antimicrobials or source control or initial resuscitation. Nothing has shown any significant mortality benefit. Despite of this, there's been a lot of efforts to look for novel strategies. So before starting with novel strategies, thinking about sepsis, so there's been different types of sepsis and septic shock, starting from bacterial, either it can be a gram-positive or a gram-negative, or a viral septic shock or a fungal septic shock. We need to identify what kind of sepsis the patient is in. So because there's been difference in ways of approaching the treatment. So because our current scenario or current interest is more of an gram-negative sepsis, I'll be more concentrating on gram-negative sepsis rather than gram-positive or any other sorts of sepsis. So the biggest disadvantage or understanding the pathophysiology of gram-negative organism, we need to identify the pathogenicity. The pathogenicity of gram-negative organism lies in its cell wall, predominantly something called as an endotoxin or the lipopolysaccharide, which is the trigger for the immunopathogenesis for sepsis in gram-negatives. But in case of gram-positives, the sepsis is not secondary to this endotoxin or lipopolysaccharide. It is more predominantly because of the exotoxins. So when you are dealing with gram-negative sepsis, your approach should be different, especially when you're doing research on novel strategies compared to a gram-positive septic shock. So I'll be talking more about gram-negative sepsis. So gram-negative sepsis, the initial trigger starts with lipopolysaccharide or the endotoxin. When it comes and attaches to the lipopolysaccharide binding globulin, and along with that endotoxin, what it activates is something known as PAMPs. PAMPs is pathogen-associated molecular patterns, which can lead to a lot of signaling cascades, and then the final release is release of cytokines, which actually acts on the host, and it will cause the so-called hyperreactive immunoresponse syndrome. In this hyperreactive immunoresponse syndrome, not only the cytokines activate the cell metabolism, they'll activate different types of complements, they will activate the coagulation system, and they will lead to something called as cytokine storm, which has been like very well which is very well actually has been studied even with COVID, and which gained its popularity. This activation of cytokine storm, what it does is it causes the florid response of systemic inflammatory response, which leads to catastrophic organ failure. So once this hyperreactive immune response phase continues, then it is followed by stage of so-called immunoparalysis, where the patients are more prone to get secondary bacterial infections because the immunoparalytic phase starts. So either there is an exaggerated hyperreactive response followed by very much hyperreactive response, which makes the patient move towards multi-organ dysfunction syndrome. Someone has raised a hand, which leads to multi-organ dysfunction syndrome and leads to the mortality of the patient. So when there's been a lot of research about doing novel strategies about sepsis treatment. So as it started with endotoxins from the gram-negative bacteria and pathogen-associated molecules, which leads to leukocyte activation producing the cytokines, and then the cytokines damaging the host cell and host organs. So this is the vicious circle which happens in sepsis. So people try to identify the novel targets for sepsis treatment. The first target has been the endotoxin and pathogen-associated molecule removal, which is the initial trigger for sepsis. And then the second target has been removal of the cytokines which are released from the leukocytes of the patient. So these two are the most well-studied novel strategies for sepsis treatment. And the current ongoing projects are on removal of leukocytes, which is the producer of cytokines. And the fourth target has been even removal of pathogens from the blood. But these 3 and 4 targets have been not that much studied, and the research is under process. So the most of the novel strategies are either targeting removal of endotoxins and these pathogen-associated molecular patterns, or the removal of the cytokines. So what we are going to discuss is about those step 1 and step 2. So coming to the rationale of extracorporeal therapies, what is the rationale? So as I said, when there is an septic insult, which is the site of, which is the starting point of injury with endotoxins, there is an exaggerated pro-inflammatory response, and then followed by an exaggerated anti-inflammatory response. In the pro-inflammatory, it causes worsening of organ failure, and in the anti-inflammatory, what it does is it causes secondary sepsis and immunoparalysis. So the idea of using extracorporeal therapies is, if you can reduce the peaking of pro-inflammatory and peaking of anti-inflammatory syndromes, something like an toxic threshold, something like this dotted red arrow, we might reduce the organ dysfunctions, and we can help in recovery of the organs, and it can improve the mortality. So that is the idea, or the rationale, one of the rationales of using extracorporeal therapies. So this hypothesis has been described as cytokine peak concentration hypothesis, because you are trying to reduce the cytokine peak by using extracorporeal therapies. And then the second hypothesis is something called as cytokinetic model. This cytokinetic model is when you're using extracorporeal therapies and removing the cytokines or the endotoxins from the gram-negative bacteria, what you're trying to achieve is you're trying to recruit more leukocytes into the organs. So these green dots actually, which is representing the leukocytes. So there will be more leukostasis or leukocyte moving towards the organs, which actually increases the fighting capacity of the organs, and which will further reduce the organ failures, and it will further reduce the severity of the MOTS, and it can improve the mortality of the patient. So these two hypotheses, one is the cytokine peak concentration hypothesis, and something called as a cytokinetic model, where you are predominantly moving the leukocytes towards the organs, actually going to improve the multi-organ dysfunction secondary to sepsis, and that's how you're going to improve the mortality. So these two are the well accepted hypotheses for using extracorporeal therapies. At the same time, what is our goal for treatment in case of sepsis is to remove the cytokines. So the question comes, by using extracorporeal therapies, how to remove the cytokines. So when we think about cytokines, as I started, the most commonly used extracorporeal therapy in ICU is something like dialysis. So when we think about dialysis, what we are actually removing is some molecules like urea, creatinine, phosphate, and electrolytes, which are called as small molecules, which are less than 500 Daltons of weight. So when you are using routine dialysis, you are only able to remove the smaller molecules. But our area of interest is the so-called middle molecules, which ranges of size or the molecular weight from 500 Dalton to 15 kilodaltons. So this is the middle molecule area where actually all our cytokines, including interleukins, all the interleukins and tumor necrosis factor, apart from the CRP, comes into the area of middle molecules. So we need to use an extracorporeal therapy where it can actually remove the middle molecules, middle to lower larger molecules. If you can able to remove the middle molecules, we can actually reduce the cytokines. So that's how our dialysis is different from using this separate extracorporeal filters for removal of cytokines or other endotoxins in sepsis. So our area of interest in treating sepsis is the middle molecules, not the smaller molecules, which is the area of interest in case of dialysis. So if you see the smaller molecules, middle molecules, and the so-called essential proteins, which are even bigger molecules, something like albumins and globulins, which are not even removed by the kidney. Apart from this, everything can be removed by the kidney. But if you are using something like a low flux dialyzer, which is for dialysis, it can remove only smaller molecules. That's why our routine dialysis filters are not going to work in case of sepsis if you are targeting middle molecules. So for targeting middle molecules, what you need to have is you need to have a special filter, which is known as high flex filter, or you need to have a special filter, which is called an adsorber, which can adsorb the middle molecules. So the filter which we use for dialysis is different, and there has to be a special filter, and then research on special filters in sepsis, because you need to target the middle molecules. So that's the whole area of interest. And at the same time, there are some other extracorporeal therapies, something called as hemofiltrations, which even target including something up to larger molecules. So if you are targeting something, some technology known as hemofiltration for sepsis, you need to have even a special filter or a special adsorber or a special dialyzer, which can even remove up to the large molecules. So the advantage of or the disadvantage of using these type of different filters is, suppose if you are targeting only middle molecules, you are targeting up to 15 kilodaltons. That's why your filter removing essential protein, something like an albumin globulin, will be very less. But if you're using something like an hemofiltration, the possibility of losing essential proteins, including albumin, will be high, because it can even remove the bigger molecules, including globulins and albumins. So that's why when you're targeting any specific extracorporeal therapy for sepsis, your goal needs to be very clear, whether you're targeting middle molecules or whether you're targeting even larger molecules, up to larger molecules. Now, at the same time, you need to get prepared with the complications, something like loss of essential proteins, including albumin. So that's how you need to choose between which type of extracorporeal therapy you want to use. And yeah, this is the same schematic representation of the filters. So if you see the first filters, this is the normal dialysis filter. So the normal dialysis filter, which has very small pores. So the pore size ranges in nanometers, which can actually only remove urea and creatinine. But if you're targeting the cytokines and endotoxins, which are more or less middle molecules, you need to have relatively bigger pores in the range of micrometers, something like 10 to 20 micrometers. If you are using these kind of filters, then only you can take out the middle molecules. As the pore size goes on, something like a plasma filter or some filters we use for plasmapheresis, the pore size even further increases. But increase in the pore size, what it causes is it causes more loss of albumins and essential proteins. So you need to prepare for the complications too. So your choice of filter actually depends on what kind of molecules you want to remove. And currently available extracorporeal therapies, they are actually very much advantageous, because they can be easily integrated into routine procedures, something like dialysis. If the patient is on ECMO or dialysis or in cardiopulmonary bypass in operating room, we can actually integrate these special sepsis filter, and it doesn't require any special training for our ICU nurses or the dialysis technicians. And it is very easy to use, and it requires very little work effect, and it doesn't require any special anticoagulation. So these are all the advantages if we are thinking about using these extracorporeal techniques for sepsis. And at the same time, you should be more cautious, because these filters have some special material and special drugs, which I am going to discuss in the further slides. So if any of our patients having hypersensitivity to these drugs, we should be cautious. And at the same time, these filters can cause thrombocytopenia and can cause granulocytopenia, like any of our dialysis filters. So patients with thrombocytopenia and granulocytopenia, we need to be a bit more cautious. So their role in neutropenic sepsis is relatively questioned compared to non-neutropenic sepsis. So in neutropenic sepsis, they're not very much well studied, and more or less it's a relative contraindication. And the material what we are using in the extracorporeal filter can get absorbed into the blood, and it can cause some systemic side effects. So these contraindications are relatively few to use these extracorporeal techniques for sepsis. But the advantages has been, the biggest advantage is it doesn't require any special training, and it is easy to be used with any of our dialysis machines. And coming to the principles, so the extracorporeal techniques actually works on two principles. One principle is the so-called adsorption, and other principle is called as convection. So what is adsorption? So which we read in physics, adsorption is any of the material gets adsorbed onto a surface. So what these filters which have the capacity of adsorption, what they does is all the cytokines and the inflammatory molecules gets adsorbed onto the filter, and then filter gets saturated, and that's how it removes the toxins and cytokines. In case of some filters where they use convection as the more principle for removal of cytokines, they works on the principle something called as solvent drag. What is solvent drag means? So in the filter, actually the patient's plasma or the patient blood is separated from the dialysis fluid by a membrane. So in using the so-called hemofiltration, what we do is we add on the ultrafiltrate fluid towards one side of the membrane, and we create a pressure across the membrane. So along with the solvent, the middle molecules like interleukins and cytokines gets dragged across the membrane, and they actually come into the ultrafiltrate. So that's how it works on the principle known as solvent drag or convection. So few actually techniques, they're purely based on adsorption, and a few techniques of extracorporeal cytokine removal works on convection based, and few filters actually works on both the principles. So the adsorption based principles are actually, there are 4 different types of filters available. They're known as cytosorb, which we most commonly use, and other is toremixin, and the third one is something called as Alteco LPS adsorber. And then the fourth one is from a Chinese company which has been gained its popularity during COVID. It is known as Saffron HA330 filter. And among the convection-based principles, there are 3 different types of principles. It is known as high volume hemofiltration and plasmapheresis and so-called high cutoff membrane. So it is known as HCO membrane, where the pore size is relatively bigger. And filter something known as Oxaris AN69, which works on both principles of adsorption and convection. And there's a new technique known as coupled plasma filtration and adsorption, which actually works on both principles of adsorption and convection. So this is like a bit too much for like those who are early into the critical care, but this is how the current the filters or the extracorporeal therapies works. So I'll go in detail about the most commonly used filters. So one of the first or initial or well-studied extracorporeal filters is the toremixin filter. So toremixin filter is nothing but a polymyxin B filter, so which IV polymyxin, which we use for most of the MDR organisms. So in this filter, actually, what it contains is, when you look at the cross section, it contains hollow fibers made up of polystyrene, and on this polystyrene, polymyxin B is already coated with polymyxin B. So when blood goes along these hollow fibers, what it does is polymyxin B is an cation, and then the endotoxin of gram-negative bacilli is a anion. So this anion and cation, they will have reaction, and they will get adsorbed onto these polymyxin filters. So it basically works on the principle of adsorption. Because it works on the principle of adsorption, the filter saturates easily, so you can't run it like any other filter, which we can run something like 24 hours. So Usually it is used with any of the dialysis machines with relatively low blood flow, something like 80 to 120 ml per minute, and maximum the filter can be used up to 2 hours. But if you are using beyond 2 hours, what happens is the filter gets absorbed or gets saturated, and it is not going to be useful. The biggest advantage of thoramycin is it is actually absorbs only endotoxin, which is the initial trigger. But if the patient is already had good amount of cytokines, cytokines cannot be absorbed with thoramycin filter. So it is specific for only endotoxin removal. There's been minimal side effects of thrombocytopenia and granulocytopenia with the thoramycin. So the main principle is because the polymyxin gets attached to the endotoxin, which is the lipopolysaccharide, the further release of interleukins and cytokines will be reduced. But it doesn't show any effect on the cytokines which are already there in the body. That is the significant disadvantage. So this is the very well studied or good evidence for this thoramycin filter. So there's been initial small-sized randomized control studies from European Union and from Italy, which showed a good amount of mortality benefit. That's why it gained popularity in mid 2015s. But the latest trials or the current trials have not shown any good amount of mortality benefit. That's how it is more or less out of the market, and the usage of thoramycin filter in all these cytokine storms has been very less. And then second type of filter is cytosorb. I'm sure like all of our ICU colleagues at least have used one time this cytosorb. So what this cytosorb contains is it contains actually a polymer beads. So if you look at the cut section of the cytosorb, so cytosorb contains these round shaped polymer beads which actually absorb the cytokines. So this has an absorbing capacity for all the molecules which are less than 55 kilodaltons. So it is more or less specific for middle and early large molecules. So the biggest advantage of cytosorb is because it actually absorbing already formed cytokines, it actually reduces the inflammatory response, and there's been good amount of evidence to show reduced organ failures. So it has been studied extensively, and there's been cytosorb registry also from which is US based registry. It has shown there's been almost near 100% removal of almost all interleukins. It can be used up to a duration of 24 hours, and maximum it can be used for 2 to 7 days. So apart from the cytokines, it's been used even in burns or something like an rhabdomyolysis, where the systemic inflammatory response syndrome has been very high, and it's been even used to post-op cardiosurgical patients where the circuit response or circuit systemic inflammatory response has been high. So it is not only it is not very much specific to sepsis. It's been even used in COVID and other non-infective conditions like burns, pancreatitis, and rhabdomyolysis, or something like in post-op cardiac surgical patients too. So regarding the evidence, there's some amount of mortality benefit, but the disadvantage is this is an observational study, it's not a randomized control trial. There's been no bigger RCTs on cytosorb, it's more of a case series. But the good or biggest advantage is reduction of interleukin 6 levels and all the cytokine levels. There's been all these softer endpoints like ICU recovery and ICU stay, ventilator stay, and organ failures recovery has been faster with cytosorb, but it doesn't postulate into good mortality benefit. And then third type of filter which we use routinely is the Zafran HA330 filter, which actually gained its popularity during COVID. So Zafran HA330 filter, which is actually it's a resin. So the filter actually contains a resin adsorbent, which actually absorbs all the interleukins, TNF. And the biggest advantage is no other filter absorbs CRP, but this filter absorbs CRP. And same, it's also used with a dialysis machine for a duration of around 2 to 4 hours. Because it's an adsorbent filter, it gets saturated early. So beyond 4 hours, the usage is less. So there's been minimally studied. It is studied in less than 100 patients in 2 RCTs. what it has shown is it has shown some promising result in terms of ICU mortality. This is what Zafran, the Chinese company, claims, but we need to be cautious in looking at the results because the number in each RCT has been less than 50. So this is one more filter which is actually gaining its popularity. And the fourth one is, it is known as Altico LPS. LPS is lipopolysaccharide, which is the endotoxin absorber, which is more common in the European Union. The difference between toremixin and this LPS absorber is, toremixin is, again, it absorbs LPS, the lipopolysaccharide. Here, the adsorbent material is an polyethylene disc. So if you look at this, the absorber, it contains polyethylene disc, which actually absorb endotoxin for a lowest volume. So the dead space for the circuit is something like 20 ml. Again, it is also used only up to a duration of 2 hours. Beyond 2 hours, the absorber capacity, it actually saturates and it is not useful even if we continue. There's been 3 smaller studies on LPS absorber, but none of them shown any mortality benefit, but there's been good improvement in softer endpoints like reduced requirement of vasopressors and decreased endotoxin levels. And apart from these techniques based on the adsorption, the previously well-studied other techniques of extracorporeal therapy for sepsis is based on the convection mode, which is known as high-volume hemofiltration. So the high-volume hemofiltration, as I said, it works on the principle of transmembrane pressure gradient for solvent drag. So what it does is we are actually adding some high volume towards the patient's blood side, and the middle molecules, along with high volumes of ultrafiltration we are giving towards the patient blood, gets dragged across the membrane, and along with that solvent drag, the middle molecules gets out of the membrane, and they can be seen in the effluent. So whatever effluent we'll get in this high volume hemofiltration fully full of cytokines. So what does this high volume hemofiltration does is, as I said initially, so because you want to remove the middle and early large molecules, you need to use a separate high flux dialyzer. So that's how this high volume hemofiltration is different from routine hemodialysis or routine CRRT, which we use in our ICU in hemodynamically unstable patients. But if you're using a high flux dialyzer, your continuous renal replacement therapy can be a part of high volume hemofiltration. So again, the dosage of high volume hemofiltration, it has to be as high as something like 35 to 45 ml per kg per hour. You need to use an effluent rate of somewhere between 2 to 2.5 liters. And the biggest problem with high volume hemofiltration, because we are using high flux dialyzer, and there's been a lot of fluid movement across the membrane of dialyzer, there will be big electrolyte disturbance. There will be a lot of electrolyte problems. And if you are using antibiotics, giving antibiotics, because you're using high volume hemofiltration, your antibiotics will be lost also in this solvent drag. So you need to use extra doses and extra volumes of antibiotics if we are using high volume hemofiltration. And at the same time, there's good amount of essential protein loss and essential nutrient loss, which we need to address specifically with high volume hemofiltration. So this is the biggest study for high volume hemofiltration, which is known as Ivory study, which actually compared 70 ml versus 35 ml. But even with both higher volume hemofiltration, there's been no significant difference in the mortality. That's how it has lost its importance in sepsis management. And the other are commonly used technique, I'm not sure about Vizag, but other places about extracorporeal therapies is something known as a specific filter, which is known as Oxaris filter. So Oxaris filter is a specific type of filter because it has an integration of 3 membranes, 3 structures. So it has 3 layers. The first layer is an basis structure, which is made up of polyacryl nitrite. Why I'm saying this? Because this filter actually works like a routine dialysis. And on top of that, there is a polycation layer which actually absorbs the endotoxin. Along with that, there's an heparin coating on this filter. So the biggest advantage of this filter is this filter can be used as an dialysis filter. At the same time, you can use it as an endotoxin removal filter. So you can use as a specific extracorporeal therapy filter for sepsis, along with along like a dialysis filter. All other filters which I have described so far, they are only used to removal of endotoxins and cytokines, but they can't be used as an routine dialysis filter. But this Oxaris A69 filter can be used like both dialysis filter and endotoxin removal filter. That's the advantage of this filter. But the biggest disadvantage is it can be used only with the Prismaflex, which is the CRRT machine, not the hybrid CRRT machine. And apart from that, we have new or coming up filters which are known as high and mid cutoff membranes, as I described initially. So they have relatively large size. And the advantage of these high and mid cutoff membranes is they can be used as both dialyzers and at the same time to removal of cytokines and endotoxins. I'm not sure whether these are available in Vizag. So the prototype is something known as Terranova dialyzer, Terranova filter, which actually prepared by the Toramixin industries. So the Toramixin people, they have come up this Terranova dialyzer, which can be used as both extracorporeal therapy, the sepsis removal of cytokine filter, along with the routine dialysis filter. So both things can be done with a single filter. And the newer coming trend is something known as coupled plasma filtration and absorption. There's been recent trials ongoing on this. So what it does is it actually does both the principles of adsorption and plasma filtration. So it uses 3 different types of filter, where the initial filters, the blood is taken from the patient, and the initial filter is a plasma filter where the plasma gets separated, and the separated plasma gets adsorbed onto the cartridge, which can actually absorb endotoxins and cytokines, and it goes to a hemofilter which can be used for further removal of cytokines, and at the same time it can be used even for dialysis for your fluid removal also. So this is a new technique for extracorporeal therapy in sepsis, but the cumbersome process is it uses 3 different types of filters. So definitely cost effectiveness is a big issue, but there's been initial trial which is known as the compact trial, which actually shown mortality benefit, but the compact trial 2 trial which is ongoing, and we're waiting for the results. So among all the 7 to 8 type of filters which I have described, so the most commonly used are these 5 types of filters, I'm sure, and among these 5 also, maybe the 4 are more or less commonly used. The Toramixin filter, which actually adsorbs or removes only endotoxin. So it is used for as a 2-hour session total, not beyond 2 sessions, or it can be used for 2 days. After that, it's been not studied and it's not beneficial. It doesn't remove cytokines, but the cytosorb, it doesn't remove endotoxin, but removes all the cytokines. It is studied up to 7 days and up to each session up to 24 hours. And then the new or the Chinese filter is the HA330 Zaffron filter, which can be used up to 2 sessions, each session lasting for 2 to 6 hours. It can actually remove only cytokines and free hemoglobins. And these first 3 filters, Toramixin, cytosorb, and Zaffron filters, they are just only the cytokine or endotoxin removal for sepsis. They can't be used as an dialysis filters. So if the patient is with AKI and requiring dialysis, you need to use a separate filter for the dialysis purpose, because they can't remove your smaller molecules like urea, creatinine, or phosphate or potassium. And at the same time, they works on the principles of adsorption. So the dialysis or removal of routine molecules is not going to happen. But Oxaris filter, as I said, it works both on the principles of adsorption and hemofiltration. So it can remove endotoxins and cytokines. At the same time, you can use it like an normal or routine dialysis filter too. But the biggest disadvantage is it needs to be used only with the Prismaflex filter, which is the Fresenius Kabi's own machine, and this filter is also from Fresenius Kabi. And LPS adsorber, I don't think it's available in India. It's more of an European filter. So these 5 filters are more or less very well studied. But looking at all the things, there's been definitely unanswered questions regarding extracorporeal therapy. It looks a bit of interesting to use these filters to show that, like, we are using all these advanced approach to sepsis. But if you look at the literature, there's been a lot of unanswered questions, especially when to use these kind of filters. So everyone has their own threshold and criteria. There's no definitive guidelines to use something like we should use on 2 vasopressors or more than 2 organ failures or something like that. So there are no specific indications. At the same time, are they going to work in every sort of sepsis? Something like an abdominal source versus lung source versus an device-related sepsis. Most of the extracorporeal therapies are studied in abdominal sepsis. So if at all abdominal sepsis is the reason for our multi-organ dysfunction, maybe we should keep relatively low threshold for using any of these filters. And among, as I said, there are like 4 or 5 most commonly used filters. Which one to choose? I'll try to come to a conclusion which one to choose, but none of the studies have shown or none of the guidelines or bigger societies, either ESCCM or SCCM or ANGIX, doesn't recommend which one to choose. And at the same time, when we should start using this filter, at the same time, after how many days or how long we should not think about initiation of these filters, because the therapy has been initiated late. So how early is early or how late is not very well defined regarding this usage of these filters. And at the same time, there's been some amount of optimum duration for using these filters, but no one has studied beyond 2 days or 2 sessions of extracorporeal therapies. And at the same time, suppose if we are giving, like if you are using dialysis, we'll see the response by looking at our potassium clearance or the creatinine clearance, or other smaller molecule clearance or acidosis clearance. But these extracorporeal therapies, once we have used in sepsis, we can't actually, there is no definitive recommendations whether to see or how to assess the response, whether the filter has worked or not, apart from the clinical response. And at the same time, there are no major contraindications, but definitely neutropenic sepsis is more or less a relative contraindication, and along with other contraindications to the fibers or material of the filters. At the same time, the evidence which we have, so as I shown around 5 filters, the toremixin is the only one which is studied extensively in bigger studies. And along with that, high volume hemofiltration, other modalities of extracorporeal therapy, which has been very well studied. Apart from that, none of them have been very well studied, especially in ascites, for a lot of other issues. And at the same time, as I said, how to choose this filter, I'll try to come to a conclusion, especially patients with septic shock. The patient can be with a renal failure or cannot be with a renal failure. If the patients who are with a renal failure, what I would say is try to use a filter which can be used both for dialysis, at the same time which can use to removal of all these endotoxins and cytokines. At the same time, if the patients are not with any sort of kidney injury, if the patients have only endotoxin level elevated or cytokine, something like a measurable cytokine, which is IL-6 is elevated, try to go for only these specific filter, either endotoxin removal filter or an cytokine removal filter, rather than going for both combined dialysis plus cytokine removal filter. And what is our biggest problem, especially in corporate ICUs, is patients or people ask for assurance when we say about these kind of filters. These are new in sepsis and it might work at the effect of some cost. So we need to look at the cost benefit, and we need to convince the family to use this filter. So I'll try to, like, this is after having my discussion with all the suppliers of these filters. I try to come to an financial aspect of this filter. So in kind of an corporate setup, corporate ICU setup, so cost is definitely a biggest issue at the time of patient benefit too. So each filter costs at least costing from 50,000 to as high as near 1 lakh, along with the type of dialysis machine we are using. Something like toromexin, the filter costs 50,000, along with the routine dialysis machine can be used, which cost might be a 10,000 extra in ICU. So it costs around 60,000, and cytosol costs something like 1 to 1.1 lakh, and Zaffron filter, which costs around 75,000. And the biggest problem with Oxaris filter, which actually uses only the Prismaflex CRRT machine, which might go up to something like 1.2 lakhs for using this filter. And there's been a new filter, something known as hemophile filter, which might be the future of extracorporeal therapy in sepsis, which can be used both as an dialysis plus sepsis filter. It costs around 30,000, and at the same time, it can be used with a routine dialysis machine. So it is not very well studied so far. It is there's been coming up for case series, especially during COVID. So it costs somewhere around 40,000. So when we are thinking about some advanced therapies, which is not very much proven in terms of benefit at the cost of nearing 70,000 to 1 lakh, we need to think twice whether it is going to be really beneficial or not. As an evidence-based guy, I'll try to look at what is the current evidence say, having read about all these guidelines. So starting from Surveying Sepsis Guidelines, which is the guidelines globally, starting from 2012, there's no specific mention about blood purification techniques. So there is no word about extracorporeal therapies or blood purification in sepsis. But when we came to 2016, there's been 2012 to 16, there's been a lot of research about all these filters, and there's been positive trials on toromexin filter. So 2016 guidelines tried to make a comment, try to make an effort to put blood purification techniques. So what they recommended is they didn't recommend any use of, they didn't make any recommendation. That's what they meant in 2016. But when we came for 2021, sorry, this is not 2016, it's 2021. What they said is for adult patients with septic shock, they suggested against using polymyxin B hemoperfusion. And at the same time, they said there is insufficient evidence to make a recommendation on the use of other blood purification techniques, something like cytokines. I think, as I said, toromexin has been very well studied, but there is no mortality benefit. The biggest disadvantage with polymyxin is because it works only on the endotoxin. It doesn't work on the cytokines. Suppose if the patient has already good amount of cytokines, as we know, removal of endotoxin is not going to work because the damage has already happened. But regarding other cytokine filters, there is no good amount of evidence so far. So what is my take on the evidence? So after looking at all the studies among all the filters, including high volume hemofiltration, the biggest disadvantage about the studies is there's been, it is studied in population or the patients where the mortality has been very much heterogeneous, ranging from 25 to 60%. And at the same time, as I said, something like high volume hemofiltration has been not studied about antibiotic dosing. So they did all kind of hemofiltration, but they didn't try to add on extra dose of antibiotics, or they didn't look at whether the antibiotic has reduced because of the hemofiltration. At the same time, they didn't look at the albumin loss and other essential protein loss, which might have affected the mortality. At the same time, there's been good positive evidence on improvement of the soft endpoint, something like improvement in the organ failures or decrease in the requirement of vasopressors. And at the same time, because of the non-selectivity of cytokines, it might even reduce the duration of immunoparalysis stage. But if we look at Surveying Sepsis Guidelines, there's been only 3 things which actually shown mortality benefit out of 93 statements. But despite of all those 93 statements, only 3 statements are shown mortality benefit. We still follow 90 of the other statements. So what I want to conclude here is, especially when the patients are having sicker patients, where they have higher SOFA scores or higher MOD score, and significantly sicker. So significantly sicker depends on individual intensivist. I can't categorize. I would prefer to gain some more time so that the conventional therapy of antibiotics and initial source control and initial resuscitation is going to work. To get that benefit, as Dr. David initially mentioned, patients with multi-drug resistant organism where we have given all the so-called intermediate to sensitive antibiotics, but this patient is still shocky and worsening organ failures, where I would prefer to use these kind of filters to gain some time so that my conventional therapy is going to act. And at the same time, if the patients who are already on RRT dialysis, I would try to use a filter which can be both can be used as a dialysis filter along with sepsis filter, which is something like the newer filter, the hemophil filter, to get added benefit of the filter. And at the same time, I would prefer to use it early. But if you ask me how early is my early, I have doubt. So by the time I would convince the family with this financial aspect and all these other issues, maybe I might lose that time of being early. At the same time, I would happy to conclude that extracorporeal therapies, they are not the standard of care in sepsis and septic shock, but these three are my priorities and my conclusions, if at all I want to use. At the same time, regarding type of filter, what I would prefer to use, patients with septic shock, if they are requiring need of RRT, I will try to use continuous veno-venous hemodiafiltration if I have a Prismaflex CRRT machine. And at the same time, I would prefer to use the Oxaris filter and hemophil filter, which can be used both for dialysis and for sepsis. At the same time, if the patient is not requiring RRT, but still patients having high SOFA and MOTS score, I still want to use, I would try to avoid toramyxin, which is the PMX, polymyxin B filter for sure. But if at all I want to use an filter which can actually reduce the cytokines, whether it's a cytosarb or the Chinese Zafran HA330 or 380 filter. So this is my take on. So here I would like to conclude, and I would be happy to follow the discussion and happy to take any questions.
Yeah, Dr. Rajesh very well presented with all the details necessary. And I would request some of you to put your questions, and some of you can ask questions. I would unmute all of you. Just give me a sec.
Yeah, it already unmuted, sir. You can individually unmute.
Those who
don't unmute everybody. It may become a noise way.
Yeah.
Who wants to talk, they can unmute.
Yeah, please unmute yourself and ask questions.
First of all, I want to congratulate Rajesh and also team of the President and Secretary choosing a good topic on this sepsis day. But a very good topic, and he enlightened everything about the pros and cons of the this endotoxin dialysis and chemo. And I think one question, Rajesh, you want to tell in the end of the thing, the patient is in a multi-drug resistant patient. If the bug is resistant, the endotoxins, if you remove the endotoxin, what is the use of? Is it any use of it? The patient is, Dr. Rajesh, my question is,
Understood,
the bugs are multi-drug resistant, MDR.
Yes,
then the patient is a multi-drug resistant patient without you didn't have any antibiotic. If you remove the endotoxins, what is the outcome of the patient? Only unless the bug is not able to.
Yes, sir. Sir, thank you, sir. That's a good question, sir, actually. So that's why, sir, if you see my last conclusion slide, what I did was patients without requiring need of renal replacement therapy, avoid toramyxin filter, because toramyxin filter is the filter which actually absorbs endotoxin. And rest of the other filters like cytosorb or this HA330 or 380 filter, they absorb cytokines.
Yeah.
So we are not absorbing endotoxin. So endotoxin removal has been not shown beneficial with mortality, sir. So don't go for endotoxin removal, go for cytokine removal. That's what the conclusion is. So that's why even Surveying Sepsis 2021, it says don't use polymyxin B filter. At the same time, they will make a comment saying that there's insufficient evidence to use of other filters.
Yeah, I have a, remember I have a 10 years long back, not in a more than 10 years back, cytosol absorber is the most commonly, I think 1 or 2 times we used it, I think in our Sakapatnam also, Rationale also, we tried only cytosol, but at the time only, that is only the available cytosol absorber.
Yeah,
that we tried, but we didn't have any benefit about it.
Yes, sir.
Cytosol absorber.
Yeah.
And also, ultimately, unless your infection control, source, what you told, the source control and the identify the bug and the treatment of the antibiotic, everything should be done. And this is only hyper acute response of the sepsis. You can control it by the only. Otherwise, unless without controlling the sepsis, you observe it is only endotoxins or cytosol, cytokine reactions.
Yes,
only the this is a should be when the patient is not responding to your antibiotic, especially to the vasopressors, other things. That is only the thing is you can once you decrease of these cytokines, the patient can respond to your treatment, especially the hemodynamic stability and everything is improved.
Yes,
at the same time, we should. I want to. What I want to say is, still the antibiotic and source control is the first and foremost if you are doing this also, even though if you are without a proper antibiotic use and only the control of the cytokines, I don't think it is also, and the primary treatment should not be hampered. And it's only the secondary, only to improve the outcome. If anything is cytokines will be, hemodynamic stability will be improved and the patient outcome may improve once this can be used. I hope that is, I hope I understand from this your lecture.
Yes,
very good. That is your presentation, very good, nice. Congratulations. Sir.
Thank you, sir. Thank you.
Thank you. Yeah.
Any more questions and contributions from the group, please?
Dr. Rajesh,
Sir.
Your conclusions are very good. And as Dr. Kujal Babu said, it's adjunctive therapy. It's not a main therapy. As you said, your conclusion is very good of not standard of care, but at the same time, it's a coincidence that today we used both cytosorb and oxalis. Oxalis for with Prismaplex with one pregnant lady with papal sepsis, and another is DVT with cellulitis, and we have used for cytosorb. But we don't use cytosorb because the cost is little more, and we use a Delvin company which is little lesser cost, which comes around 70,000. So in my previous organization, when I was working, he was very much comfortable using a ECT therapy, Dr. Venugopal. He has used oxalis more than 5 to 6 patients. And the time of early, what you are telling is that the early means what he has noticed, what he says is, when you use that, as soon as inotropic support is requiring, and in spite of not recovering with the fluid, and the shock is still come, like Vitek report has to come, and you do not know. So at that time, using the filters is much beneficial, and you can see, because now what happens is, as you said rightly, when you are discussing with the patient, by the time they accept, the time is gone. So that is where the problem comes. When you are, see, as you are telling in the beginning, in the first itself, correctly, every 2.8 seconds, one person is dying. And you are given all the 5 filters. We have used all the filters except the last one. Even the HA330 also has been used. But the filter using is one of the late stage we are using, just like ECMO, just like putting a ventilator at the end, they don't give consent. So all these things are really problematic with us, because if you see any country where the insurance is taken care, there the timing issue will not come. Here, whatever you said, if it is a government case of Arogyasri, we don't get money. As a cash patients, by the time you give consent, the time is over. So otherwise, unless you have a numbers to prove that which is beneficial, it takes maybe another decade for us to come, which is beneficial. So your explanation regarding toramycin, everything, filters are very good. And thank you. This is, I think, regularly in the Vizag, regularly people are using filters. Very nice. Thank you.
Thank you, sir.
Rajesh,
Sir.
very good and excellent talk. You have done very extensive work on filters and usage. My question is, you said toramycin used for removal of endotoxins and all these other removal of cytosorbs, right?
Yes, sir.
Can we use both the filters to remove endotoxins and cytosorbs alternatively like that?
Sir, theoretically, I would say yes, but practically, I don't know. So the question comes actually like if you're removing, which one needs to be first? So endotoxins and cytokines both will be simultaneously, right? So I'm not sure, sir. To be frank, theoretically, I would say yes, we can use.
Okay, thank you.
It can be used. If you have the ECMO on and an RRT machine going, you can use it in parallel or in circuit, depending on what you're treating.
Okay.
Do you have experience, Dr. Gurunath? Have you ever done that?
Oh, yes.
Okay.
Because invariably, if you go on the ECMO, you're going to have renal shutdown. And all these are usually weak recommendations. The strength of evidence as well as strength of recommendations is also very weak. You just use it because you don't have another, another way out of it. You're trying to save the patient. But again, you have to ask yourself, ethically, is it right? You're going to spend a lot of money. Insurance, yes. Even insurance also, they pay to a certain extent in India and even overseas. You don't get everything. So it is a very expensive, labor-intensive process. What is the outcome? No one knows.
Yeah.
All these filters are, yes, fancy stuff you can get, but nothing, no strong evidence. That's the main problem. You can never get evidence because you cannot conduct a study saying this guy goes on this filter, that guy goes on this filter. When the patient is dying, you have to use everything you have. So invariably, that's why they have the registry. So you just collect from the registry and do a meta-analysis backwards.
Yes, sir, very well said. Actually, like we can't even get an RCT also, like when to recruit and like we can't have like 2 arms or 3 arms or like a combination arms. And at the same time, like recruitment is also will be an issue.
Yeah, you can't recruit because it's ethically not feasible.
Yep.
Your, committee won't allow you to conduct the study because you cannot deny it. That's the whole problem. That's why it's the tip of the iceberg we are still struggling with regarding sepsis. Either we don't know the etiology or what's the word they use? Pathobiology of sepsis, because we just can't dig it at the micro level. It's all at the macro level that we seem to be convincing ourselves. That's why the recommendations as well as the evidence is so weak. It is, but one thing I would love to know from you, I mean, do you think personally, with such low evidence and recommendations, do you think it is ethical for us to really try all these fancy therapies?
Okay, so yeah, what I would say is I would like to use it, especially young patients, someone like any sort of search response in young patients. Like we had sometimes, like it's not very uncommon to have a MODS etiology without any identified diagnosis. We label it as some viral etiology. Patient will be like in front of us, like kind of sinking with bad vasopressors, requiring intubation. You feel like you will be in a situation, if you intubate, patient is going to crash down. So where you can actually see the cytokine storm or the search response has been like catastrophic. Like yes, in those situations, yes, I would try to convince the family to go for cytokine removal.
Stage now your patient needs intubation, he need all the support that is required.
Dr. Gurunath, the way I handle the situation here is, we don't know whether we are ethically right or wrong because we don't know the evidence. But I would like to put myself in the patient's family, and if I would do the same for my family members, I would try to push it across to the family. But usually what happens is it's too late before we get the acceptance by the family, because it involves a lot of money. So it's not easy to answer whether it is ethical or not, but we have to imagine ourselves to be their family members, and we should decide, is what I feel. And most of the times we would be correct if we follow this approach.
It is not unethical.
I would try to
What
give the
I feel
benefit
is,
to the.
no, we are not at all unethical. Unethical once you say this treatment 100% success, we will say. We never say it. You show what is the results. We already telling the therapy is there. We don't know the result won't be, not a success may come, it may not be there. But the results are we already discussing. The statistics you are telling, so many cases are done. The results are with this much of poor. Only 1 or 2 patients are success there. Then there's no unethical. If you say if you do this thing, the patient is 100% success. If you say unethically, it's shocking. But you are doing when if we are able to convince the same thing, what is in the theoretically we know it. We tell the patient is not it is ethical. If you say the unethical words, if you go for this treatment is 100% success, that is unethical.
Yeah, my conclusion will be, I try to give the benefit, especially for the younger patients. I'll try to give the benefit of doubt to the patient rather than. I don't feel it like a non-ethical thing.
Rajesh,
Sir,
nice presentation. Actually, sir, it is not a fancy treatment. It is actually good treatment. Those who are experienced actually will start advising the patients, because this is the time is Rajesh what I to explain is time is very, very important. So really it is working very well, sir. That is why, what is the future of this treatment? Any future of ECMO, this one extracorporeal therapy, Rajesh? Any idea?
Yeah, my take will be, sir, like especially for Indian scenario, it all comes to cost cutting. So what I feel is currently there's something like the hemophil filter, which is
yeah, you explained that one. So one more thing, just I wanted to add. DBAG actually adding these filters to another inertial forces. So by creating that in European, there are so many trials are coming. He is doing actually with a PathX purifier filter, which removes the 99% of gram-positive, gram-negative bacteria along with all endotoxins. So it is a future is there, for especially when we are dealing with a multi-drug resistant organism. So it is not at all fancy. So people are improving to start early treatment as well.
Sir, like I think you're talking about the step 3 and 4, which I tried to describe initially.
Yeah.
So this one,
With the 4.
Yeah, removal of the bacteria along.
So if any more
any questions in the chat box, you read that.
Yeah, just let me check. There are no questions, but someone commented that that was too much of information on filters. I think probably unaware of the topic, because the whole topic is on filters and extracorporeal therapy. So if you got exhausted, we are sorry, Mr. QCOM BTD, right? Yeah, thank you for contributing to the chat box. Thank you. And
Rajesh, Rajesh, can ECMO consider as an extracorporeal therapy in patient with septic shock? Like you said, immunoparalysis, multi-organ failure, and persistent shock, not responding to high-dose vasopressor therapy.
You mean to say VA ECMO, sir?
Yes, VA ECMO.
No, sir. So septic shock, refractory, pure septic shock? No.
Dr. David sir, my question is, ECMO can be considered extracorporeal for sepsis
therapy in septic shock.
Okay.
Refractory septic shock.
It is extracorporeal, but it is not. We don't use filters there, right? ECMO. Only for gas exchange.
Membrane is an extracorporeal therapy.
No, I'm not talking about whether you use filters or no, don't use filters. Extracorporeal topic is extracorporeal therapy.
Okay.
So can you consider it as a extracorporeal therapy in case of refractory septic shock?
Yeah. Sir, at the same time, I try to put across question. So
Anything is out of the, when the blood comes out of the corpus and go and circulating, it is called extracorporeal. Anything, even the water dialysis,
Extracorporeal.
simple
The name
dialysis
is
also causing extracorporeal.
Sir, patient with severe
Dialysis also
dengue
called
shock.
extracorporeal.
Patient with a severe dengue shock, can we use ECMO?
No, I'm not talking about dengue
Yes,
shock.
yes,
Exactly.
Rajesh.
Yes, yeah, exactly. So that's what. So any refractory shock, suppose patient with septic
Anything
shock having
refractory, we
severe-
should go for ECMO, Rajesh.
Sir?
Anything refractory, just buying time to save.
Patient with bad septic shock with septic cardiomyopathy, poor LV, yeah, of course, we ECMO.
My understand is to a patient in refractory septic shock, and patient can be put on ECMO plus use this filters for the removal of the endotoxins or cytokines, whatever.
But if it is pure vasodilatory shock, I don't think ECMO is beneficial, sir. It is only if you have associated some cardiomyopathy and cardiac component, then only it will be like you can think
Without cardiomyopathy or severe LV dysfunction.
pure refractory vasodilatory
Yes,
shock.
vasodilatory shock, because sepsis itself is a vasodilatory shock and not responding to high dose vasopressors. You want to put on extracorporeal therapy, can be used on ECMO and this filters for both the purpose.
Yeah, for that I think we can use it.
Yes.
Okay. So Dr. David, sir, the closing
Yeah, we will
conclusion.
close the session. Thank you very much, Dr. Rajesh, for a wonderful session. Maybe it is a new topic, but it's very useful for all the students and residents and even clinicians to know about this, because nowadays patient attendants are asking, is there any other treatment modalities to save the patient? In that context, they have money and they want to try everything. Definitely, we can go for this. As you said, patient is young and their patients are well affordable. Then we can give the option. So for that, we should know what are the therapies available and what we can try more than the use of antibiotics. I request Dr. Achyut to conclude the session.
Thank you very much, Dr. Rajesh, for preparing on this difficult topic and presenting it excellently with all the minute details related to this. And I'm sure and you have touched almost all aspects of extracorporeal therapy. And with this knowledge, we should be able to go for more analytical thinking of the situation, and probably it should result in more usage of extracorporeal therapies. I'm happy that Dr. Mohan Maharaj and Dr. Mohan Rao, they did 2 extracorporeal therapies in a single day, which is a really big achievement, and I hope that spreads and diffuses to the entire Vizag. Thank you very much, Dr. Mohan Maharaj, for giving us that information. And I thank Dr. Kuchelu Babu and Dr. Gurunath for their contribution to the discussion, which made it more energetic. And I thank all the participants who logged on to this webinar and showed their interest for this topic. Thank you very much, and we'll conclude. Thank you.
Thank you, everyone. Good night.
Thank you all. Thank you, Rajesh, for you particularly. Thank you all for your wonderful participation.